Hello. Welcome, everyone. So sorry for the a little bit of delay. Right as I'm about to start, hit play, my mouse decides it doesn't want to work. So, welcome to my day. But a little reboot always helps. And we are back. We are live, and we have Dr. Erin Foster. And we are so excited to bring you this Giving Tuesday event. Giving Tuesday is an international day of giving, and that doesn't mean just you giving to us, it means us giving back to you. And so at LSSN, we are all about evidence based education, we are all about supporting you, and we're all about empowering you through information. And so today is no different. So I'm excited to bring up Dr. Erin Foster. She is a vulvar dermatologist and an LS specialist. She has a long list of credentials. You can learn more about her on our website, our medical. She is part of our medical advisory board. We are so excited to have her on. And I'm going to bring our guest up. Thank you so much, Dr. Foster.
Thank you guys so much. I'm so excited to be here. And I've been really nervous and really looking forward to this. So my plan is to present for a short period of time and then take questions if that's okay.
Absolutely. So, guys, I have dropped in the room there the top post. You can drop your questions in the comments under that post, and when Dr. Foster is done with her presentation, we will go through and get your questions. So, I'm going to get out of your way, Dr. Foster. Just you see the present button, and you are good to go to present your slides when you're ready.
Okay, can you guys see that? Yay, okay, I think I can see it, so I'm gonna just start talking. So this is lichen sclerosus from a dermatologist perspective. I'm Erin Foster. My Ph.D. is actually in skin immunology, so I love this topic. I think it's really interesting from an immunology standpoint. I'm in the Department of Dermatology in Portland, Oregon. I have to do a disclosures and conflict of interest. I am a member of the medical advisory board for the Lichen Sclerosus Support Network and just thrilled to be working with them. I have been working as a consultant for Arcutis Pharmaceuticals for genital psoriasis, and then I'll talk about my work as co-principal investigator for the core outcomes for lichen sclerosus symptoms. I don't have any conflicts of interest. I'm not somebody who is taking a lot of money for lichen sclerosus work. I've only used clinical photos that are publicly available, and I've attempted to increase the representation of skin of color, which is obviously a long-term problem in the field of dermatology. I removed the photos of genitals that were previously in my talk so that this can be more widely available. So the goals, we're going to talk about the epidemiology of lichen sclerosus, meaning who gets it, the clinical features, what does it look like, some new unpublished work that we have on patient-reported outcomes in lichen sclerosus. What does it feel like? It feels a little silly talking to this group about that, but I think we're very grateful that this is becoming more publicized, the patient outcomes. The pathophysiology, very briefly, and then treatment. And then I have a slide for the holes in the current landscape of knowledge and practice. As I'm sure you all know, this is a very understudied, under-researched, undertreated condition. So we'll talk very briefly about that and then go to questions. So epidemiology of lichen sclerosus, who gets lichen sclerosus? This is actually a very complicated question to answer. We were taught that it is bimodal. It happens in premenopausal girls. It happens in postmenopausal women. It happens in men of all ages, but there's some recent studies coming out that shows that that may not be the case. So this is a study from Finland showing that on the y-axis here in the top, can you see that? There we go. So this is the number of women per 100,000, and this is their age as they get older. And instead of having it as a hump here and a hump here as young women and postmenopausal women, it's actually showing an increasing number of people who get lichen sclerosus over as they age. There's some other data from a recent study in the United States showing something fairly similar, which is that women from 45 to 65 were sort of the main group getting lichen sclerosus, but that it was also present in everything from 0 to 44 and above. The regional breakdown in the United States was interesting because more women in the South seem to be suffering from lichen sclerosus. This is just women. Obviously, lichen sclerosus also affects men and non-binary people. This has been very poorly described, but we do know that it can affect everyone from male babies to older men as well. So clinical features of lichen sclerosus. So I'm going to show you pictures of extragenital lichen sclerosus in a minute, but the key thing is that it's shiny, white, wrinkled areas on affected skin. And the way as a dermatologist, I think, is that what I see on the skin is what I will see under the microscope if we were to take a piece of the skin or a biopsy. It usually leads to thin, fragile skin. Sometimes the vessels are very apparent in those areas. There can be swelling, there can be redness, it can be accompanied by bruising, cuts, open sores, bleeding. As it's healing or changing, it can change pigmentation. So it can be hypo or lighter than the person's normal pigment, or it can be hyperpigmented or darker. As I'm sure most of you know, uncontrolled inflammation can lead to scarring. The medical term is remodeling, which sounds much nicer, but scarring of the tissue if it hasn't been treated. I always make a point to talk to people about how this is a chronic, lifelong condition, how it is treatable but not curable, similar to diabetes, similar to psoriasis and eczema, because I think it's really important for people to know that at the beginning, rather than be looking for a cure, although I'll talk more about hopes for a cure later in the talk. So what does LS skin look like? These are these sort of classic white, wrinkly patches of skin here. They say it's atrophic or it's like cigarette paper. And they can be discrete little spots or they can group into one big plaque. In a little bit darker pigmented skin, this white area here, I hope you can see my mouse, is the area of active lichen sclerosus. This is a biopsy scar. This is a Band-Aid. These are areas of healing with hyperpigmentation, like I discussed before, and it can get a little bit thicker as well there. This is another person with darker skin coloring, and these white areas are the active lichen sclerosus. In a lighter person, the areas are very, very shiny and white and can sometimes be only distinguished by the texture changes. And then I'm showing you kind of common areas of involvement besides the genitals. Breasts can be often involved. And as I was trying to show here, the kind of thinning of the skin that shows more of the blood vessels. So again, I know this is a group of people who are very interested in lichen sclerosus, so it felt a little silly to talk about what it looks like, but I think it's nice to see kind of an overarching theme of how it can look in lots of different skin types and skin colors. For the next thing that we're going to talk about are symptoms. So patient-reported outcomes in medicine are another word for symptoms. And the question is, what does LS skin feel like? As you can imagine, experts were not particularly aware of this. And so there was a group that was created called the Core Outcomes for Lichen Sclerosus group. And it has a subgroup called the Symptoms group. Corals is shorthand, and you're welcome to look that group up. And this group, I have been helping to lead, and we sent out a survey to LS advocacy groups, including LSSN. It went internationally. We had 863 respondents complete the survey. All of the respondents currently said they had genital lichen sclerosus. The vast majority were female sex, given at birth, assigned at birth, and female gender identity. And every age group was representative. Most were, of the respondents were 41 to 70 years, but there were a few pediatric as well. So this is unpublished data, and we're planning on publishing it. I have already shared most of it with the LSSN and the other advocacy groups, but we asked patients to rank how important these symptoms were to them. And so this is the ranking. So I'll just walk you through it. So the rank is 1 is the most important, obviously, and 15 is the least important. And respondents said that itch, burning, pain, cuts or tears in the skin, and rawness were sort of the top 5 of their symptoms. We also wanted to know, of these, how important are they? And so this is kind of a rank distribution. So for most people, itch was the most important, which is why this is kind of a larger red bar. And then the least important was difficulty with defecation to the most number of people. But this is kind of the list that we had started with as experts on this disease. And I found it really interesting because we wanted to see how this matched up with what the experts had done. So we knew that we had missed things. And so I had put in an open respondent question of what symptoms are missing. And these were the symptoms that we had not included that people, respondents to the survey, told us were important. So stinging, obviously loss of clitoral sensation, tingling, prickling, heat sensitivity, moisture, numbness, anal itching, sticky skin, and throbbing. So this is just one part of this group work that we're doing to understand not only how does lichen sclerosus look, meaning the clinical signs, how does it feel, what are the symptoms, and then there's an entire group that's addressing the quality of life impact, which we haven't even talked about here, including impacts on sex, impacts on self-esteem, impacts on daily life and choice of clothing. And in my clinic, we ask those questions at every visit, like how is the application of these messy creams affecting your life? How is it costing you? Can you afford your medicines? How is this affecting your overall quality of life? So we did notice that the survey results for symptoms were similar to expert responses. It's a busy slide, but on the left are the respondents to the survey, and on the right are the steering committee responses. We had asked the experts to come up with their own list. And at the top are itch. Burning was listed and was not listed very high for the experts. And so that's something we've learned from the survey. Pain, cuts, and tears were also highly ranked, and thankfully those were similar. So we are really happy to have the first large-scale symptom survey of lichen sclerosus, because what's shocking is that this work has not yet been done. Nobody has actually gone out and just asked patients how they feel in a large scale way. So the question of the pathophysiology of lichen sclerosus, or what causes it, is very similar actually to other skin diseases. So psoriasis and eczema are similar in that they are due to overactive immune cells in the skin. That's how I describe it when someone comes to see me in clinic. The name lichen actually means a band of immune cells, and sclerosis is what the collagen or the stretchy tissue of the skin looks like under the microscope. And so it's named for how it looks when it's biopsied. It's similar to psoriasis, eczema. It's obviously not the patient's fault. It's nothing that they've done. It can be genetic and pass through families. It's associated with certain HLA types. And there have been associations between families. We know that that is true. But there has not been a single gene that's been identified as responsible for lichen sclerosus. We know that certain branches of the immune system are elevated, and certain communicating molecules between certain cells are elevated. And so I am hopeful that targeted therapy is possible, as it has been found to be possible for eczema and psoriasis. This is a little bit more detail. We do think of it as an autoimmune condition. There are different types of T cells or immune cells that calm down inflammation, and they seem to be less active. And there are certain immune cells that increase inflammation. They seem to be more active. There's also, we know, this change in the structure of the skin, the collagen, the way that the skin heals and scars. And we also know that there's a change in how the vessels and the bleeding can help to heal. And there's also changes in how the cells grow and regenerate. This is a great, for anybody who's interested in the pathophysiology of lichen sclerosus, this is my reference here. We're going to move on to treatment. So as I'm sure most of you know, many patients with lichen sclerosus are undertreated. As doctors, we often talk about why are the patients undertreated? Why are they not compliant? And so we talk about steroid reluctance. They're not sure how to use it. They're unsure where to apply it. There's certain formulations that are uncomfortable, wondering about side effects. Does it interfere with sex? Oh, they don't come often enough. And then any sort of the quality of life, the denial, the shame, the avoidance. But I like to put this up when I'm teaching about lichen sclerosus and point out that providers often contribute to the fact that patients are undertreated. So either providers are not examining the genital skin. Many dermatologists don't even look at the genitals during a routine skin cancer screening. They don't recognize it, lichen sclerosus, if it's seen. So OBGYNs often are just kind of going in to the vagina and not looking at the skin. OBGYNs usually recognize it better than a primary care or dermatology. Providers themselves have steroid reluctance. They're unsure how to prescribe. They don't know how to explain where to apply them. They don't know how to monitor, is the person getting better or not? There's discomfort with the formulations. Different providers don't know if they can switch things out. And again, same thing, infrequent visits. And honestly, the provider a lot of time is very uncomfortable with the whole topic of lichen sclerosus, mostly because they've never been taught. So just a quick blurb on treatment options. For most patients, if they do find someone who recognizes what they have, clobetasol is given to them and they say, okay, go ahead, put your clobetasol. And people get all sorts of different instructions on how to do this. Clobetasol is a very strong topical cortisone medicine and works great for some people, but isn't for everyone. And so I have kind of a list of things that I think are very, very helpful. Just kind of first line. So if people want to use clobetasol, they can, the generic way that everyone is taught who knows about lichen sclerosus is twice weekly for prevention, increased to daily for flares. But if clobetasol doesn't work for someone, there are other options, just like in psoriasis or eczema. There are more mid-level cortisone options that can be used 3 times a week, like triamcinolone, or daily, like hydrocortisone, and they basically perform about the same level of control as clobetasol. This has not been studied in a randomized trial, so it's just my clinical experience. In terms of other treatments, gentle care, bland emollient, meaning, dermatologists love Vaseline, but coconut oil, shea butter, cocoa butter, aquaphor, it doesn't matter, any of it is helpful. If someone is postmenopausal, sometimes just the dryness and tightness can be relieved with estradiol cream. Sometimes our OBGYNs more frequently give neuromodulators to help with the nerve pain. And then at our clinic, sort of the last first line therapy is intralesional cortisone injections to those areas. People get it in their joints when they're having arthritis. Why would they not get it into skin where it's irritated? In terms of second line options, these have not really been well studied. I put here several different oral and injectable immune modulators. Methotrexate is the one that I've had the best success with in my patients with lichen sclerosus. And that's a medicine that's very old, has been used in low doses for a long time in dermatology for psoriasis, eczema again. I have not had good success with these other medicines. Dupilumab is a medicine that is targeted towards eczema and has been thought to be really, really specific for eczema. But I do have a few patients with eczema that I've been trying it on, and some it's helped and some it hasn't. In the literature, there are lots of reports of people doing laser therapy, photo or light therapy, fat grafting has been done. both for the comfort of the tissue. This is specifically usually in vulvas, but also because it's thought that grafting the fat from non-inflamed areas might actually slow down the inflammation. So there's not great evidence for anything except for clobetasol or mometasone, which is similar to clobetasol, a little bit between triamcinolone and clobetasol. And so most people who are providers, that's what they know to give. One of my rants that I try not to go into too often is just trying to get people to think, providers to think more creatively about this as a skin disease that we would treat like any other skin disease, like psoriasis and eczema. Just the topicals, if they're not working, then we try to move on to something else. So in my clinic, I have the patient hold a mirror if they're comfortable. I see men, women, non-binary, everybody. We often take photos that go either in the chart if the person's comfortable or on their own phone so they can monitor. I really think it's important for people to be able to know what their own body looks like and to know what active lichen sclerosus looks like versus not. I usually have a diagram and I'll draw on the diagram, where to put the medicine or where the active lichen sclerosus is. I find that to be very helpful. And then we talk through what their priorities and what their goals are, because I try very hard to recognize that I know about the disease and the medicines, but the person knows their body the best, right? So they are the expert in their body. I'm not going to push on them some medicine that they don't want, but we'll hopefully come to a shared decision together about something that's effective and will help, but something that they're comfortable doing without having to try a million different ointments and creams. So that was what I said earlier. So this part about the holes in the understanding of lichen sclerosus, I almost went down a rabbit hole with this and then just realized, you all probably know this. We don't know what the true rate is. We don't know the epidemiology. We don't know how it affects different races, cultures, ethnic backgrounds. That would be useful information. There are not even lichen sclerosus advocacy groups that we can identify in either South America or Africa or Asia. So the most active ones that I've identified are in North America, thank you LSSN, and Europe. So we don't know about that. We don't know about other best treatments besides cortisone type medicines, topical steroids. We don't know about the pathophysiology in a detailed way. We haven't tested targeted biologics. And so there's a lot to learn and hopefully a lot more to do. So for more information, here's some references and resources. Obviously, I'm very impressed by the LSSN's medical, or I guess the articles that are published. They're very high quality. They're very scientifically based. They're very evidence-based. So definitely go there first. There's some other places if anybody's interested. And then just really quickly, a shout out. We have a specialty program at OHSU since 1995. It serves women with vulvovaginal complaints. It's a multidisciplinary clinic. The OBGYNs usually see vulvodynia and chronic vaginitis and dyspareunia. I usually see lichen sclerosus, lichen planus, and these are my colleagues who I just love and adore. And I'm happy to take questions. I have a million extra slides, but most of those are just in case somebody has a question specific for it. Oh, Kathy, I can't hear you.
You would think after 3 years I would know to unmute. Thank you so much. That was so interesting to hear from a dermatologist point of view, because most of the time we're hearing from a gynecologist point of view about LS, and it was really good to hear from someone who knows about the skin, who knows all of those kinds of things. And I always learn something new from you guys. So I truly, truly appreciate it. We already have some questions coming in. I'm going to bring the first one up here. So the first question I have is, what does it mean having the appearance of white patches on the vulva, that of someone who has had LS for a long time? Like, I guess the question is like, do the white patches go away? And if they don't go away, is that a sign of VIN or a squamous cell carcinoma? They're really
Thank you.
worried about this, even though their dermatologist told them not to. They're
Thank you. Yeah, that is a great question. And I'm sorry, that's probably a big hole that people were wondering about that I didn't put in there. So let's start with we think the incidence of squamous cell carcinoma or vulvar cancer in lichen sclerosus, as far as we can tell from good literature, good studies, it's about 1 to 3 out of 100 patients with lichen sclerosus, much more common in patients who have been untreated for long periods of time, who smoke, and who haven't been to see an OBGYN and a dermatologist. That's just kind of how that's been tracked. So I think of it as a fairly low risk, but possible. I definitely have had patients who have developed squamous cell carcinoma and come to me, and we had to go from there. So when somebody has had LS for a long period of time, there's a couple different ways that it can be. Some people believe that LS can burn out, meaning that it goes through an inflammatory phase and is really wildly active, and then burns itself out and is no longer fully active. Other people believe that it's constantly sort of puttering along, whether you can see it there or not. I tend towards the second group because we know that in other conditions like eczema and psoriasis, if you were to take a piece of the skin that looks normal or healthy in people with eczema or psoriasis in a place where they consistently get the condition, that skin doesn't look normal under the microscope. And so it's already got the changes going on microscopically that we know will lead to the condition. So I think the hard thing in lichen sclerosus is to distinguish what is active white lichen sclerosus and what is scar tissue. And that is what is very challenging for clinicians, for providers, for patients, for everybody. And that is one of the struggles that has been, I think, slowing down research in this condition. I think that the way that we talk about it is that if it is shiny, shiny white, cigarette paper, wrinkly, and especially if it's symptomatic, then that's much more likely to be early lichen sclerosus. The color changes in dermatology, we'll debate colors of skin lesions for hours. And so the color of a burned out or a scarred lichen sclerosus spot is a little different. It's a little more yellow or pink, and it has a little bit different texture. Again, I wouldn't expect anybody to know that without having gone through a lot of training. So I think the most important thing is to continue treating, continue going to see your dermatologist. But if you're not happy, then, it's always okay to ask for a second opinion.
Thank you. Okay, our next question is, can you give us some tips on how asking our healthcare providers to examine our perineal skin? Most gynecologists only examine the vulva.
That's a great question. Thank you for that. Because I almost had it, but I didn't, was the typical figure 8 distribution of lichen sclerosus that we talk about. So that means vulva, perineum, and around the anus. Most OBGYNs, I think, are going to be perfectly fine if you ask them to do it. I think it's something that they aren't expecting. So probably before you're up in the straps is a good idea. I think if they know that you're there for lichen sclerosus, they absolutely should be examining those areas, because the perineum can be such a part that gets fissures and cuts so often that needs to be examined. I think what I've learned through finding out how understudied this condition is how important patient advocacy is, and people speaking up for themselves, which is horrible to put the burden on the patient, but is, I think, how it has to be done. So I think asking, saying, I have symptoms here, it seems related to my lichen sclerosus, could you take a look, is absolutely the best thing to do.
I agree. I was just doing a live this morning and I was saying the same thing. It's unfortunate that we have to create this space, that we have to fund this space, but this is where we are right now. And until we can get the attention of the bigger organizations, the hospitals, the our government to give us the money to get the resources and to fund this, this is where we are right now. So yes, advocate for yourself. Same thing goes for the clitoris. A lot of doctors don't, pull back the hood and look for phimosis, look for adhesions. So ask your provider to do that. I went to the dermatologist and I was having some itching around the anus, and I was like, "Hey, can you take a look back there?" And she's like,
Yeah. And the dermatologist should. That's where they should be looking. I mean, my skin cancer experts at OHSU, they get in there and they spread the buttocks and they look in the vulva because they're worried about, people getting skin cancer there. So dermatologists should be looking.
"We should." All right. So next question is this is, thank you so much for sharing about the discoloration that can take place after healing. I'm completely dark down there and was so worried about it being cancer. Now it makes sense. So,
Yay! Yeah, post-inflammatory hyperpigmentation. Just Google it, and it's in most skin conditions, um, and it can be terrifying if you don't know what it is.
yep. Does the itch scratch cycle cause the fusion? Should a less potent steroid stop the itching? And can you fuse so much you can't urinate?
Oh, these are great questions. So those are all really good questions. So the first one is, does the itch scratch cycle cause the fusion? What we think we know from a couple different studies is that the inflammation itself causes the fusion. So whether you're scratching it or not, the inflammation would be causing a fusion. What we do know that the itch scratch cycle does is it causes the thickening of the skin. And so what's interesting is that lichen sclerosus is this thinner, white, shiny skin, but because it's so itchy, it gets rubbed a lot, and anything that gets rubbed in the skin gets thicker. And so it can be both sort of similarly at the same time. In some of the vulvar pictures I showed, I have kind of the thin skin right next to the thicker rubbed skin. Okay, so that's the itch scratch cycle. Can a less potent steroid be just as effective? Yes, for itching. Yes. So in my experience, I have several patients who, for whatever reason, either are not interested in trying clobetasol or have tried it and it didn't work, or it didn't feel right, or it burned or something. And so we've tried different other topical steroids that are not as strong. I would say the difference is that we just use it differently. So it's just like eczema in my practice, where if somebody's using a very strong cortisone, they use it less often. If someone's using a weak or a medium strength, they use it, medium number of days. And if somebody's using a weak one, they use it more often. So for example, for people who don't have a dermatologist, I would recommend going to the store and getting hydrocortisone 1% ointment, and you can use that daily on the vulvar skin with really very, very few side effects long term until you can get in to see a provider. The one that I most often use is triamcinolone because it seems to have less of a reaction in most people, and it absolutely helps people decrease the itch. I will say, though, this is another plug for patient advocacy. Lidocaine is super, super helpful, and your provider should be prescribing lidocaine, topical lidocaine ointment. But if they're not, again, it's available on Amazon. The creams usually burn more, and the ointments usually are a little bit more soothing.
Thank you.
And
And
then
then
there
the
was a
last
third
question,
question.
can you fuse so much you can't urinate?
Yeah, so that is, I have some patients who we talk about using dilators. And yes, so there's two areas that are the most common for stricture of the vulva. So if we were using a diagram, thank you. So the anterior commissure band would be sort of up top, just below the clitoris. The posterior commissure band is just above the perineum. And so if you can imagine, if your urethra's up here, and you have a scar of an anterior commissure band, then that can block urination. And what that ends up looking like for the person is that they end up spraying urine And
Mm-hmm.
so instead of having a single stream as they pee, they're like, hey, why is my urine going everywhere? So
Yeah.
yes, definitely it can scar so much that it can really dramatically change your urination pattern. And that's really important to tell your provider if you find them. A urogynecologist can be helpful for that. And then also gynecologists are helpful for any kind of surgical release if that's something that you're interested in.
Yeah, I have another question around the same path. Can narrowing of the urethra through scarring lead to UTIs? Now, I've heard narrowing of fusing over the urethra, I've heard is very, very rare. But the labia fusing up in front of the urethra, I've heard that's a little bit more common. Even though it's not very, very common, it's more common the band on the above the
Posterior.
perineum. Is that correct?
Exactly. Yep. So the if somebody has scarring of their urethra, then I don't. In general, we don't think they're talking about lichen sclerosus anymore. They're probably talking about lichen planus, and those two conditions can be confused for each other and exchanged. And we could talk offline about all of those things if anybody's curious. Lichen planus is more likely to affect the vagina, the urethra, internal organs. Lichen sclerosus generally stays confined to the skin areas. But yeah, so if the lichen sclerosus is causing that sort of anterior scarring, anterior meaning closer to the clitoris, then yeah, it can definitely affect the urination. But it
And
is more common.
that backup can cause the like a UTI, right?
Yeah,
Yeah.
exactly. So if you're, yeah, same thing. If you're spraying your urine. So again, this is why for most people who have frequent UTIs, I ask them to either see a urogynecologist, which of course is a year-long wait, or get D-mannose online because it's a supplement that can help prevent recurrent UTIs. It's basically harmless, but helps really with that problem.
Awesome. How often are biopsies needed in early LS, and is it better to work with a dermatologist or an OBGYN or both?
So I have gone back and forth on biopsies. When I first started, I thought I don't need to biopsy people. Why would I put people through this pain and suffering if clinically I can tell what it is? I still think that that's probably true. I prefer for people to get a biopsy with me than with someone who's not used to biopsying the vulva because I use topical numbing and then we use
Mhm.
ice and then we know how to do it so it's not horrible. Um, but I think there are enough conditions that look like lichen sclerosus that probably a biopsy can be very useful. And in specific situations, so if someone is not responding to treatment or if it's really unclear as to what they have, I think a biopsy can be very, very useful. But again, most people don't want to go through the trauma of having a piece of their genitals cut off of them, if not needed. And I get that. So, the other question was about who to work with. I think
Mhm.
you work with the provider who listens to you, who's willing to engage and do reading about things that they don't know. I think if you have a dedicated genital dermatology OBGYN clinic in your area, that's where you should definitely go if you can. Those are usually at academic centers, but those are few and far between. We have patients who come from Alaska and Montana and Wyoming. So, I mean, the most important thing is that you find someone who's willing to listen. It can be a nurse practitioner, it can be a primary care doctor, it doesn't matter. Because your experience of the condition is the most important part of treatment. Because what I have noticed is that if a patient, most of the patients who come to me have seen previous providers and have either been told the wrong thing or been actually traumatized by the medical system. And I find it to be the hardest part of my job is undoing the damage that other providers have brought. So
Yeah.
that's not
That's
sorry,
why
that's a little
we
bit
that's why we do what we do, so we can get to people early, so we can minimize the medical damage that is done when people don't get enough information, because the information is there and people can manage this. They just aren't told that, and they're flailing in the wind, progressing, and things get worse, and it's so unnecessary, so unnecessary. All right, we got a bunch of questions. I know we got about 15 minutes left. So, um, guys, if you're finding this helpful, donate so we can have more of these live events. All right, here we go. Is clobetasol ointment truly better than cream for healing?
Oh, that's a great question. So the thing about cream versus ointment is whether or not you'll use it, right? So some people will only prescribe ointment because it has fewer preservatives. It soaks into the skin better, weirdly, even though I know it doesn't feel like it. And it's less irritating to the skin because of that lack of preservative. But if somebody hates putting on ointment, there's no reason to prescribe ointment, right? Because then they're not going to use it. So cream works great, right? So if the question is, yes, we know that ointments in dermatology across the board, they have been studied to get into the skin better than creams and irritate it less because they have fewer preservatives. But it sure doesn't work if nobody wants to use it.
Yeah.
So if you don't like clobetasol ointment, that is okay. Just get some cream and use it instead.
Yeah, we always say if you're using the cream and it's working, don't worry about it. If it's not working, try the ointment. My thing is if it ain't broke, don't fix it.
Yeah. Some people like the solution or the spray, and I've never understood that because they're alcohol based and I just think they would burn, but whatever works
Yeah.
is fine.
Yeah. Okay, so someone asked, what do you think about the red light therapy available at like Mommy Matters? Is that an option? And if so, how often to use it? I don't know if you know in particular that
I don't know Mommy
specific.
Matters, but I know
Okay.
red light therapy. It does not have enough data for me to be able to be endorsing it yet or proposing it. I'm not recommending it to anybody, but I'm excited about the thought. I haven't had anybody who's tried it be cured.
Mhm.
And my main thing with sort of unproven therapies is just I don't want people to spend a ton of money on them if they don't have it. So in general, I'm always for people trying whatever works for them. But there's not enough data on the red light therapy yet for me to recommend it.
Yeah. And what we've heard anecdotally is that it can help with the skin, the way it looks, and kind of healing the skin, but it's an adjunct. It's not going to take over your steroid. You use it along with your steroid, and it's just to help you kind of heal faster.
And there's something to be said. So I've wondered about just phototherapy or narrowband UVB, which is also used in psoriasis and eczema. And why can't we just have like genital phototherapy? That's never been tested. And it's used in conditions that are very similar to lichen sclerosus, like morphia, and is very effective. And so I suspect that is an area that hopefully will have more data in it over the next few years.
Yeah. Okay, so next question. This is did the survey capture what parts of the vulva are the most commonly where LS is found?
We only asked 6 questions, and it was so hard. I really wanted to ask 150, but we asked to capture the symptoms. But it has been studied where on female genitals where lichen sclerosus is the most common. The most common area is the labia minora, or the non-hair-bearing lips. After that, it's kind of a toss-up between clitoral hood. That can be kind of an early area that can fuse early, perineum around the anus. But no, we did not ask patients where they have it most commonly.
Yeah. I'll tell you, it's talking to hundreds of people with LS, and it's all over. There's like no standout. You just get it all over. Okay, next is how do you most often proceed if clobetasol helps improve the look of a patient's skin, but they still have symptoms?
Yeah, that's a great question. So, of course, it matters what are the symptoms. So, I have conversations with people. If it's itching or pain, then we make sure that they definitely have lidocaine on board. They have anti-itch treatments that we would use for eczema or psoriasis, like hydroxyzine or Benadryl. If it's more like pain with sex, then we do lots of pelvic floor physical therapy referrals. I talk through dilators because a lot of the time, for most women with LS, at least, they have at least some part of guarding of their pelvic floor muscles that get really tight because they've had, if they've had penetrative sex with lichen sclerosus, it's been painful. And so then that pain loop kind of can obviously become the most rational thing for your body to do. And so we send people to pelvic floor physical therapy. That's been very helpful. If their symptoms are problems with urination, then I have them talk to a urologist or a gynecologist, or talk through the urinary tract infection kind of prevention methods. Dry skin, we always talk about estradiol cream if somebody's postmenopausal or perimenopausal. It just kind of is very specific to what their additional symptoms are. But I do always recommend that clobetasol continue to be used on an ongoing manner, to kind of, because we know that skin is just going to come rearing back if somebody misses the treatment.
Yeah. Yeah, I was going to ask if you work with a pelvic health physical therapist as a dermatologist, because we love our PhDs. They're great to have on your team. And we have a lot of blog posts on our website. So use the search button. There's a lot of information on how pelvic floor physical therapy can help with LS, even though it is a skin condition. There's a lot of secondary stuff that happens because of your LS. So, all right, next question.
Was that our timer?
Let me see. My next
I forgot to mention constipation, which nobody ever remembers to talk about except including me. If people are constipated, I always just make sure that they have a little bit of Miralax, because LS around that's actually very common in pediatric patients with LS around the anus, is they'll have severe constipation because it hurts to go poo.
Mm-hmm. Which makes sense, right? Yeah. And again, there's your pelvic floor physical therapist to kind of help too with constipation. All right. We have a lot of questions. Someone asked, can pain from intercourse be relieved with LS? I'm guessing
yes.
I feel like there's something missing from that question, but yes.
Yeah, so, of course. I mean, that is something that I love about my job, is talking to people about how to make their sex lives either more creative, so it just doesn't have to be penetration. I had one slide that I took out where they were just quotes that patients had said to me, like, I wish my husband got a girlfriend to have sex with, because I don't want to have sex with him anymore, and it hurts so much. And people hear, it's a huge bag of worms that we don't have a time to talk about today. But yes, I have definitely had patients who are, if they want, they're able to go back to comfortably having penetrative intercourse. And if not, then we talk about other ways to have sex. It's not all about penetration, and talk about kind of other ways to express sexuality.
Once again, we have so many blog posts on our website, lssupportnetwork.org, on this subject, and it is absolutely possible. We've got so many people going through the virtual meetups and just talking through email, supporting them through the process, that can have gotten to pain-free sex. And I have a podcast episode on exactly that, figuring out other ways to have sex in the meantime and still have that intimacy that doesn't include penetration until you're able to have that. Okay, I know we're running low on time. Real quick, let's try to rapid fire some of these. Does LS affect the bladder? We kind of talked about this, but just a yes or no.
No, it does not directly affect the bladder, no.
Okay. I have white patches of skin on my eyebrows. This is getting a little, we can't give medical advice, so I'm going to skip that one real quick. What do you recommend as first steps post childbirth?
That's a great question. Yeah, so that is a time when lots of people flare, similar to postmenopause, and I would say be really aggressive with treatment. Use a lot of whatever your favorite moisturizer is at the vulva skin too. So put a moisturizer on it if it's cocoa butter, shea butter, coconut oil, whatever. Make sure that pre-birth there's stretching being done of the areas affected by LS. And then just be really gentle. Give yourself grace. You're going to be exhausted and have a new baby. And nobody heals well under those conditions. So just take it slow.
Absolutely.
Use your cortisone.
Yes. So if someone's had any kind of reconstructive surgery down there and their LS is well managed, um, do you recommend them continue using do you recommend the steroids still be using on a maintenance or just use it as needed?
That's a great question that, again, doesn't have much evidence behind it. So if it's been reconstructed and the areas with LS have actually been cut out or removed surgically, then there's less of a reason to use the clobetasol or whatever steroid on an ongoing basis. But if that is not the case and it's just been like a clitoral release or phimosis release, then yes, definitely, because I've definitely seen patients who have had surgical revitalization or reconstruction of their vulva or penis, and then it came back, the scarring came back because of active lichen sclerosus.
What strength of lidocaine do you recommend?
Oh, I like lidocaine 5% ointment, but literally anything works.
Okay.
The main downside to lidocaine creams and gels is they can burn when you put them on, so that's why I'm partial to ointments, but whatever. It burns for 5 seconds and then it helps you for a while.
How do you treat anal LS?
Same way. So interestingly, I don't have people put clobetasol quite as often around the anus as I do on the vulva. So this daily for 2 weeks kind of prevention. I like to use triamcinolone or hydrocortisone around the anus because the skin's a little bit thinner there, and the perineum. But however, whatever works, cortisones. If somebody has a really thick spot that's very painful, I'll inject it with cortisone. Lots and lots of Miralax and fiber to make your stool soft.
Yeah, Dr. Cross says the
Not
same
over
thing.
cleaning. Oh, and
Sometimes
bidets. Have I mentioned bidets? Yeah.
Oh, we love bidets.
Yay, bidets. Yeah, get a bidet.
Yes. Go
Don't
on our
scrub, don't use
website, look
wipes.
up grooming, look up the blog on grooming. Great. We talked to a gynecologist all about grooming with LS, using the bathroom, bathing, all of that good stuff. Bidets, number one. Can an LS cause a significant drop in sex drive? I have zero and have been trying to figure out why and wondering if LS could be the source.
Yeah. So, I mean, I think anything that causes pain definitely decreases sex drive first. Then LS can often be associated with a dip in hormone level, which also we know decreases sex drive. So, I always recommend that people go to see their OBGYN, talk about menopause if that's where they are. But in most cases, people with LS don't really want to have sex because or even any kind of intimacy at the beginning when they're trying to figure it out, because, even hand holding leads to pain. And that's a very logical, rational way for the body to respond. To protect oneself from pain. So absolutely. Yep.
Yeah, we always talk about the
I don't know that it's like biochemically. Yeah, go ahead.
Yeah, we always talk about how like LS doesn't cause it, but your body is your unconsciousness is always taking on these triggers, right? And if it's a trigger with sex causes you pain, your unconsciousness is like, okay, we don't want to do that. We're going to decrease the libido. We're going to make it so that you don't want to have sex. We're going to do all the things to make it so that you are not put in that position to feel that pain. So while it's not directly causing it, it's an indirect effect of the LS. And so when you heal and you're feeling better, then you can do things to get that libido back up. Awesome. And then someone says they were prescribed betamethasone. Is clobetasol better?
No, I think betamethasone works fine.
Yeah, we have someone actually who uses betamethasone for their flares, and they use over-the-counter hydrocortisone to stay in remission. So it's all what your body needs.
Listen to your body. You know it best.
Exactly. It's whatever your body needs. How can people contact you? How can they get in contact with you?
So I was thinking about that, and I don't really know. I mean, what do you think is best, Kathy? I mean, I can give out my office number. I don't necessarily find it helpful to give out my email. I don't know. What do you guys want? I have 2 small children that I am never home enough for. And
Yeah.
I also have a full research and clinical practice. So I want to be available, but not like answering emails in the middle of the night. So maybe I can work with LSSN and figure out like certain ways to be available to answer questions if that's helpful.
Yeah. If
Our
you
wait
guys
list
have
is
questions,
ridiculous.
what we could do is email your questions for Dr. Foster to support@lssupportnetwork.org. And then what I can do is just filter them to you, and we just give you them in like, a chunk rather
Sounds
than you getting
wonderful.
like a bunch of random emails. Okay.
Yeah, because I'll not sleep. I'll lose sleep over them. I
Yeah.
think about stuff while I'm
Do
sleeping,
you,
and that's not good
do
for any
you
of
have
us.
social media?
No,
No.
zero.
Okay.
I'm
Yep.
off. I'm off social media entirely. Sorry, world. I know you miss
No
me.
worries. Well, now, if they want to come and see you, so you could be their doctor,
Yeah.
they can go to the
So that's
OSHU.
ohsu.edu/dermatology.
Okay.
And then we have a vulvar clinic webpage that's, not new or fancy.
No worries.
But if they just search OHSU vulva, they'll get to Vulvar Health Center for Women's Health. And I have clinic there 1/2 day a week. And my colleagues are OBGYNs, and they're there much more often than I am.
Awesome. Well, this has been super
Uh-oh.
helpful. Thank you so much.
I think our time is up because I think we froze.
Oh,
there we are.
Okay. This has been super helpful. I am so happy that we got to learn from you today. And guys, like I said, if you want to have more sessions like this, if you want more educational content, fund our education fund, drop a few dollars in the donate button up in the upper right hand corner. Every dollar helps. $5 a month if you can only do that.
And just to be clear, I'm donating my time. I'm not being paid for this. I really believe in this group and this advocacy group. So absolutely, please donate if you can, because I really appreciate the work that you all are doing.
Thank you so much. All right, guys. Thank you so much for spending your Tuesday with us. And we will see you next time. Bye.